Hello everyone and welcome to our webinar. It's the first this week for National Fertility Awareness Week and thank you for joining us. I'm Kate from Fertility Network UK and this evening we're going to be discussing the findings of our new survey which was carried out with Middlesex University looking at the impact of fertility problems. We're joined this evening by Ephia Yasmin from the British Fertility Society. We have Clare Ettinghausen, who's the Director of Strategy and Corporate Affairs at the regulator, the HFEA, and we've also got with us Angela Pericleous-Smith, who's the chair of the British Infertility Counselling Association, or BICA. We've got quite a few questions to get through, which we've got in advance, but if you've got any extra questions, you can just put them in the Q&A box or in the chat and we'll get through as many as we can. We are recording this webinar, but don't worry, your questions will be anonymous. We won't read out anyone's names. And the webinar should be available within the next week or so on our website. You can find all the webinars on our webinars page. Before we start, just a quick reminder that we are a charity and everything we offer is free of charge, but we are very grateful if you do feel able to make a small donation. Can you do it now through text, which is very quick and easy, and you can text FNUK3 to 70085 if you'd like to make a one-off donation of £3, or FNUK5 to 70085 for a one-off donation of £5. We're very grateful to anyone who does feel able to make a donation. It makes a real difference, so thank you very much. But now we're going to get on with our discussion this evening. Our survey was a very big survey of more than 1,000, nearly 1,300 people affected by infertility, and the emotional impact that it highlighted was huge. The vast majority of people who responded, that's 83%, felt sad, frustrated or worried, often or all of the time. Nearly half of the people who replied had experienced feelings of depression, and 4 out of 10 had experienced suicidal feelings, with 10% saying that they'd experienced those feelings often or all the time. Ephia, I wanted to come to you first about that because this survey really does show what a huge impact fertility issues can have. Do the findings surprise you?
Sadly, they didn't, because the experience of infertility is well recognized in scientific literature as well as one of the major drivers for emotional distress and mental health issues. So sadly, I was not surprised. But of course, what also came clear was that with support, maybe we could do a lot to alleviate that. I don't think we can claim to totally eliminate the issue, but I'm sure we can do more. And certainly, Claire's here today, but the HFEA has put in patient support as central, not as an optional extra, but central to the care delivered during any fertility treatment.
Claire, I wanted to come to you about this next. I mean, do you think clinics need to do a bit more to be more aware and perhaps to offer more emotional support to patients?
Well, I think I think the survey showed just how hard the impact of fertility treatment can be on patients. And our own patient survey from last year found that something like less than 65% of patients were satisfied with the support they received from clinics, whether that's through formal counselling or through support groups or informal support. What I would say is that as the regulator, we have to, by law, every 2 years physically inspect clinics. And we look through a whole variety of things from how the laboratory works to how safe the environment is to whether the staff are up to date with their training. We do look at what patients how patients are supported through their fertility treatment. We also look at patients can feedback on their own experience via our website, and inspectors look at that in advance of their inspection as well. So it's something we take really seriously, but we know as these findings show there's a lot more that can be done, recognising that not every patient will want formal counselling, and charities such as Fertility Network and others provide a whole level of informal support that is also plays a very important role at the moment.
Angela, I wanted to come on to that a bit, talking to you, because the depth of the kind of emotional turmoil that some people are in is really quite worrying. And we know that counselling can help and that peer support can really make a difference too. Do you think clinics need to do a bit more to actually signpost people to the kind of support that's available?
Yeah, absolutely. I mean, it was really sad to see the figures that have been highlighted in the survey, but like Ephia, not surprising. The impact is very well known. I do absolutely think clinics could be doing more to signpost. I think these days, particularly, there is such a huge range of support out there, whether that's professional support or informal support, peer support groups. FN UK, they run support groups online, they run them face to face, and everybody's support needs are different as well. So sometimes it might be webinars or podcasts or signposting to books. So I think it's absolutely vital that clinics are signposting. But I think what's really important in that is that clinic staff are aware of the various range of support and organisations that are out there to be able to signpost.
Thanks, I agree. I think it's really important because what people need can be really different, can't it? Another thing I wanted to ask you about, Angela, was something else that came up in the survey, was around the damage that fertility can do to people's relationships. I mean, do you think that's kind of inevitable to an extent, or are there things that you as a counsellor would kind of advise people to do to try to protect their relationships if they're going into this?
Yeah, I mean, again, that was another stark reporting, wasn't it? That 59% of people did report a detrimental impact on their relationship. I think, in my experience over the years, absolute key to relationships is communication. Keeping that communication open. And I think what I see time and time again is that particularly couples, they expect one another to be on the same page as them, and they're not necessarily are. And what is absolutely key is they're communicating to one another where they are. Sometimes what I hear a lot is, oh, I don't want to talk to her about it because she will get upset and she's already upset. So what's the point of making her more upset? So I often hear that from men, and that's not to generalize at all. So sometimes just developing really good communication styles between one another is really useful. And there's a range of options, from kind of having little codes between partners of when one partner wants to talk and one doesn't. And what's really, really invaluable if you do struggle to communicate with one another is what I call shoulder to shoulder therapy. Going out for a walk together and talking them, because you're not directly looking at one another, you're side by side, and it can often be so much easier. So the key to keeping that relationship stable is communicating with one another and remembering why you started this process in the first place.
Thanks, really useful tips there. Thanks for that, Angela. One of the other things which came up, and we know is always a major problem when it comes to fertility, is around access to treatment. So NICE guidance was clear on what people ought to get, which was 3 full cycles for those of 39 and under, and 1 cycle for those who are eligible of 40 to 42. But we know this isn't happening. We've seen an increase in people paying for treatment. Ephia, IVF was pioneered in this country. What do you make of our current NHS provision?
Yeah, in short, wish it was better. However, I want to speak about the positives first. We are amongst few countries where IVF is funded. So there is funding. Yes, there are criteria for funding, which you may debate, but we have funding that is accessible to all, and hope, probably we'll be talking about how to improve access, and which is preceded by the knowledge and awareness of this. So we have funding, but where the improvement could take place is in parity of this funding. because we do see a discrepancy based on region. For example, in Scotland, the funding is different. In Ireland, it's separate funding, and obviously in England, Wales. Then within England, because the funding comes from the clinical commissioning groups, and they have their own fertility policies, and they fund based on, of course, their own criteria of what they can fund. I just want to say that it is not because, people want to be mean, because I have engaged with CCGs through the years, and they are helpful people. They want to engage, but sometimes there are competing kind of interests in terms of where the funding should go. And what we can do as clinicians or anyone in the sector is lend our voice and also engage. And with engagement, we can look at removing this disparity. Certainly, this could be so much better. And the NICE guidance is it's a good kind of foundation on which to base funding on. And I will have to say, though, despite the state of the economy being how it is, we haven't seen slashing of funding. I can speak about North Central London, NCL, that has just done incredible work of engagement, including public engagement, and has, created a policy that is very, very permissive. 3 cycles of fresh and 3 cycles of frozen for people who meet criteria. So I think, we can carry on doing that which is engaging, talking about it, and looking to address this disparity.
Thanks, Ephia. I think that's a really good point. And I think North Central London is a really interesting case in point, because I think it shows that when commissioners do engage properly, as they did with experts and with the public, their conclusions are often quite positive when it comes to fertility funding. Claire, though, one of the things I wanted to raise with you is that what we see in this survey is that when people can't get NHS funding, the cost of paying for treatment privately is incredibly high. So the average cost in the people who responded was £13,750, and 12%, which is quite a high number, had spent more than £30,000. People do sometimes ask, why can't the HFEA do something about this? And I wondered if you'd like to respond to that.
Absolutely, and I'm afraid the answer is I wish we could. So our powers are very strictly set out in the law to protect primarily the embryo and any embryos created, to protect the safety of what goes on in fertility clinics. Unfortunately, we have no powers in relation to funding. But I mean, it was very nice to hear a sort of a positive story from Ephia. I suppose I'm slightly more negative, and when I tell people about the work that we do, we work in the area of healthcare where more than 60% of patients are paying for their own treatment. I mean, when you say that out, each time I say that out loud, which is 5 or 6 times a day, there's no other area of healthcare where people are having to make individual decisions at what is probably one of the most vulnerable times in their life, costing more on some than they will ever pay for any kind of single thing in their life. And it's shocking, really. And I think we should continue, despite the good news that Ephia says in her area, we should continue to be shocked. And it's very helpful to have surveys such as yours, Kate, and National Fertility Awareness Week, which raises some really high profile public and media attention on this. I mean, even within that 60% of funding, there are also quite severe inequalities. So we know, for example, that Black and ethnic minority patients have generally less access to NHS treatment than white patients. Again, as we say this, that's quite shocking. And those in same-sex relationships or single patients have almost no access to NHS funding. So there's sort of more and more inequalities as you go through it. What we have tried to do is that we can't change the funding situation. what we can try and do is provide as much helpful information for patients. So the HFDA website has a huge amount of information, including what should I ask my clinic? So, you know, why am I being charged this? What is the cost? What is included and what isn't included? And various checklists, some of which we've developed with Fertility Network, which will hopefully help patients as they go into the beginning of their treatment and into appointments to ask those questions. And we've also done some work with other regulators who do have some powers in these areas, like the Competition and Markets Authority, who set up some very helpful guidance for fertility clinics, for example, on how to present pricing information to really try and enable a comparison between clinics to be easier for patients. Because I think I found that one of the most challenging things is where one clinic might say our price includes this, another clinic doesn't include that. So the work, hopefully, with the Competition and Markets Authority, we've already seen some changes to clinic websites, and hopefully that will just enable some more transparency, which will be helpful for people in what is a kind of shocking and very difficult situation.
Claire, I just wanted to pick up on that point about the headline prices, because we know that that's often really, really confusing for patients. So they look on a clinic website and see that the patient is told it's going to cost X amount. And then you discover that actually it doesn't include virtually everything that you need to include in a fertility treatment IVF cycle. I mean, why is that? And how do they still get away with doing that?
So we hope that some of the work that the Competition and Markets Authority we should start to see those changes coming through. What I would say is when we look at, we do an annual report looking at how safe clinics are and, you know, the rate of incidence and things like that. On average, there's about 90,000 cycles of treatment across the UK, with less than 1% having any form of instance. So I really should reassure patients that wherever they are in the UK, whether they're in an NHS or private clinic, generally fertility treatment, the clinics are run well and you should be having a safe service. However, clinics also have clinic websites which are their kind of their shop window, if you like, and they are a marketing exercise. They want to attract you as the patient. Again, as I said, if you have a look on our website, there's some key questions to ask before treatment. And it's unfortunate, isn't it? It shouldn't really be that way, that the onus is on the patient to ask these questions. That is the current situation that we're in, that we have got a situation, whether it's NHS clinics where often private patients can pay for their own treatment, or private clinics that take NHS patients. It's not as clear cut as private and NHS. And they are trying to attract you as the patient. The other thing we do ask clinics to change is sometimes the success rates you may see on a clinic website, maybe for a small group of patients. And, you know, again, why should you as the patient have to become an expert on statistics? So we really just suggest that at your appointment you ask every question you can think of, but every individual should have a costed treatment plan based on their own particular needs, not based on someone else's. Take that home, really have a look at it, ask questions over email, and, you know, don't commit to anything until you're really 100% happy with what is being offered to you.
It's really useful advice. Thanks, Claire. Angela, I wanted to ask you a bit about the financial burden, because we know that it's really, you know, it really weighs on people's minds, thinking of where they're going to raise the money to pay for treatment if they need to. And I wondered, is that something that comes up in counselling sessions?
Sadly, it is, yes, and in a variety of different ways as well, that the financial aspect to fertility treatment can impact to some of what Claire and Ephia have already discussed, that different clinical commissioning groups have different criteria. So in one area, somebody might be entitled to X number of cycles, in another area they're not. So sometimes it comes up for reasons like that. Treatment is so expensive, and for some people massively saving and potentially not going out to any social events because they're saving, which in turn can have a detrimental impact on their emotional and mental health, their well-being. Sometimes people are needing to borrow money from family or friends. And then, of course, it has a different dynamic in the relationship with parents or siblings, for example. Sometimes couples themselves have different views on whether to have more treatment and the finances and what else they could be doing with that money. And I've worked with people who remortgage their houses and borrow money on credit cards, and single people as well, where there is only one household income coming in, as to whether they can afford treatment. So it massively impacts all of our patient groups, really, in a variety of different ways.
Ephia, what do you think needs to change to improve things for patients? I mean, some of the people in the survey, admittedly it was a small number, but some people had reported paying more than £100,000 on fertility treatment. I mean, how can treatment ever cost £100,000?
The first thing that we ought to be doing, and that should happen, is the first point we made, which is to bring in equality and remove the inequalities that exist in access and funding. So first is that, and then once we have achieved that, then we've got to look at what else can be done. I'm not saying these will be easy solutions and automatically they will happen. For example, we talk about 65%, but some of those 65% that make the self-funded treatments or private treatments perhaps would be secondary infertility, because having a child in their relationship precludes an individual or couple from accessing further NHS-funded care. And then there are other factors as well that may preclude them, such as having a very low ovarian reserve. They're actually the NICE guidance. Yes, whilst it is an enabling guidance, because the NICE guidance also talks about ovarian reserve. And sadly, sometimes it's the ovarian reserve or a diminished ovarian reserve that precludes someone from having care. So it's actually addressing, first is the addressing of all the barriers to NHS funding, number one. Number two is, we are in a, again, I suppose, I do see the positive side of things. We are in a fortunate situation that the fertility sector is so heavily regulated that we are answerable, okay? Anybody working in fertility more than anything else. But I'm also, of course, only talking about the licensed treatments, because sadly, there are lots of unlicensed treatments, such as, advising different types of supplements and acupuncture. I'm not saying that's bad, but there are, other enterprises that are springing up around fertility treatment. So they are all unlicensed. So in the kind of the journey, the fertility journey, yes, a couple could end up, I can see how they could end up spending a lot. First of all, from or with the clinic there, or if they've changed clinic and they haven't, say, had the outcome they anticipated in one, and they've changed. Yes, we've already acknowledged that prices do vary. Of course, I won't go into the economics of this and how the business models are made, but there are so many variables that determine how much someone pays. But this 100,000, of course, I was quite aghast saying this, but I will need to know the context. Has this individual or the couple, if there's a couple, this is a couple, have they been informed about, how many attempts did they have? At what point was closure discussed? Or did they choose to carry on with treatment? It is very difficult to unpick all of that. But is it, there are some sort of few issues that we know and acknowledge and that we have to deal with. And that is there enough funding? No, there isn't enough funding, state funding. And is there variation amongst clinics? I have to say that with the clinics themselves, I don't think it's necessarily a private versus NHS thing, because just like you have all these NHS hospitals across the country, but they have different CQC ratings. Okay, they should be governed by the same principles, but you'll get variations. And similarly, you may get a very ethical private organization and another where, you know, you might be not very happy with how they practice. So the right questions need to be asked. You know, define what your success rates are based on, and ask these questions. Yes, you highlighted, Kate, that is it on the, you know, is it the should the burden of this lie with the patient? The truth is, when especially seeking any care, NHS or private, yes, it is obviously the clinic's responsibility to deliver all relevant information that will facilitate decision making. But we have to educate ourselves, just as we do when we access anything, that we will have to take, of course, some interest in the process as well.
Thanks. I mean, that's a useful answer. I think it was more than just one patient, because although it was a small number, it was, you know, more than one people. And I think that's the worrying thing about it. But then, as Claire said earlier on, maybe one of the things that people need to do is to ask a lot of questions earlier on and go back to the HFEA website with those useful questions about additional treatments and things, and make sure that you're paying for things that you feel happy are kind of evidence-based and will help you as an individual. Another key area that came out in the survey was around information and getting enough information early enough. I mean, people were saying most people didn't feel that they got enough information from their GPs. Ephia, is that something that you see quite often when patients come to you? And what can we do about it?
Yeah. Yes, to, you know, all that you said. And I just want to, before I take your subsequent question, one thing about these add-ons, that means all the other additional investigations and treatments without any clear evidence of their benefit. Yes, all this will also add to the cost of treatment, absolutely. So they will all add up, and including the number of cycles. And if someone's needing those number of cycles, it already kind of suggests that the prognosis is poor, but, you know, should they continue? So the other question was, sorry, just remind me, your next question was?
It was about GPs and
information. Yes, GPs and information, absolutely. Now the NICE guidance, which is now going to have, you know, another update, is a very key, you know, is a key piece of document. And yes, it is the general practitioner's responsibility to be well informed. And do all patients have access, or they get the necessary investigations, and do they get their referrals on time? I would say mostly yes, but there is still a sizable section that may not. Such as, the NICE guidance is very clear, such as that if the female age is 37 or above, then they do not wait for the full, you know, year of experiencing subfertility, but their investigations need to start earlier. But does it always happen? Sadly not. So yes, more needs to be done, but what is that more? One is, you know, our responsibility, which is clinicians, nurses, or people working within the sector to deliver that information, and have webinars, CPD programs, where we can reach out to as many, you know, general practitioners to make them aware of the current guidance and practice. So we've got to do more. And the value of organizations like, you know, Fertility Network UK. So you are a huge support source, but people go there. And so you can, you know, if you carry information, then the patients also have direct access in one place to the information, so they can go and approach their GPs empowered with this information. Then there is responsibility, of course, of the general practice to be, you know, totally up to date, and to think about, you know, referral that is timely. But I will put my hand up and say, in the NHS, you know, which is under huge pressure from staffing, waiting times, etc., not helped by the pandemic, do we always get to see our patients on time? Sadly not. Again, different clinics will have different waiting times. Sometimes some clinics have a waiting time up to a year. So all these are, again, barriers in accessing timely treatment. So information, first of all, and then even with the information, to get then for this to translate into getting care in the NHS, that is another challenge.
Claire, coming back to the information provision, I mean, what does the HFEA do when it comes to clinics and actually also GPs to try to encourage people to provide the right kind of evidence-based information? Because there's never been more information out there, but there's also never been more information that maybe doesn't have an evidence base behind it.
I think it's really difficult, especially in something that's so personal like fertility treatment. So we know that people rely in all areas of life, on friends, what we call the friends and family tests, so people who we know who've had a positive experience. And actually, from our original patient survey that we did in 2018 to our most recent one in 2021, we saw people relying more and more on their friends and family for recommendations about clinics rather than perhaps going, through a GP or through a trusted source of information. And we know at the HFEA that we need to do better as well of getting our information to patients. We would like our information, which has unbiased information on all UK fertility clinics, to be the first port of call. But we know that perhaps when you're starting fertility treatment, Googling UK fertility regulator might not be the first thing you do. We do, however, by law, ask clinics to provide information, and we have a very lengthy, something like nearly 400 pages, sort of a guidebook for clinics called a Code of Practice. And in there it says, the information that clinics must provide. But as I said before, we're now in the situation where their websites are really their shop fronts. So how they're providing that information, even sometimes when you present a number or a statistics, depending what color you might put it in, your eye sort of reads something, and it's only when you read the small print you see something else. Again, to reassure people, this is something that we look at least every 2 years on inspection. And on the Choose a Fertility Clinic part of our website, where patients can give information back to us, and particularly to our inspectors, we ask, for example, if the cost of treatment was what you expected, and you can put some information there, if it was vastly different, what happened and why. When we go to clinics, we always ask if patients are happy to speak to our inspectors, if they're willing to share their experience, so we can get a kind of a full picture. And we also ask clinics for their own patient feedbacks forms, and we look at if a particular issue has been raised, for example, whether it's on cost or perhaps something else going on in the clinic. We ask the clinic to show us evidence of what they've done to change their behaviour, if you like, to reassure patients. However, we can't be in a clinic all the time. Unfortunately, in healthcare inspection, or I don't know whether unfortunately, that we're there to do kind of spot checks, and minimum every 2 years, more if we have serious concerns. But I would encourage any patient, if you have got a particular question, to have a look at our website information. There's a lot on there. I've worked at the HFEA for nearly 5 years, and almost every week I find a new bit of information actually that I hadn't seen. So there's a lot on there. There's a lot of information from yourselves at Fertility Network and other reliable sources. In this area, unfortunately, patients were sort of required to become experts, really, and advocates for our own healthcare, and that's not really how it should be, but it is sort of what we're asking people to do, to really go with as much information as possible into those appointments and ask as many questions, because you're the patient, whether you are paying for treatment or not. It's your right to give as much information and not to make any decisions until you really feel you've got the answers to those questions.
Ephia, another thing that patients often report back to us is that they'll go and see one consultant who will advise one thing, and then they'll go and see another one who will advise something completely different. And it can be really hard as a patient to know who to believe. I mean, what would you advise patients to do in that situation?
So to answer this question accurately, I would have to know the context. So if somebody was provided with conflicting information, but in what context? So let me give you an example. If you have a patient where the gentleman has azoospermia, so there is no sperm on, and say there has been attempt at surgical sperm retrieval, and they have, which has been successful, and some sperm is available, then I do not think there'll be conflicting information. So they will be informed that the treatment that would be appropriate for you, recommended for you, would be ICSI, intracytoplasmic sperm injection. If, on the other hand, a couple have unexplained infertility, which we talked about in a few webinars ago, and in that context, yes, there will be a variety of recommendations, or perhaps even suggesting further investigations to try and look into causes of subfertility. So there, that variation of advice is actually not that somebody is giving wrong advice or right advice, but because there's uncertainty, it's about the kind of the ethos of the clinician about whether they would try and perform every investigation that they are aware of to try and find something. Or would it be that a case of, or another clinician would think, I'll do the basic investigations where we have absolute evidence for, and the others where we are not certain of their relevance or significance, then I wouldn't do them. Okay, so this variation will exist. And fertility medicine is subject to huge amount of variation, because it is seldom a case of, sort of very, where the issue is very black and white. Sometimes it's about, let's try this. And what's the evidence behind it? There is some evidence. So there is this whole chunk of our practice where we do not have very strong evidence, including a common scenario such as unexplained infertility. Should we just wait? We have a young couple, should we just wait longer? But then what about time to conception? The experience of infertility, we have already recognized, is emotionally distressing. So should we just say, wait a little bit longer? Should we do something that is less invasive, but has very, low outcome? Or should we go for something more invasive? So it is in the context. Then comes, the other variables as well. We're trained in similar ways, but there will be different levels of training, okay? And also kind of understanding as well. So if you have a clinician that is hugely involved in research and is really a stickler for evidence-based, knows the research in and out, can read the research more accurately, because it is not about just having a trial, but can unpick the trial. But you say you have another clinician, clinically excellent, but hasn't done, and they don't need to, clinicians don't obviously have to do hardcore research, but can you see the perspective they will both bring can be different. So yes, but it is highly confusing for the patient. But to the patient, my advice would be, ask the reason why, ask for the rationale. And I really trust people's intelligence. So when we discuss, including where there is uncertainty, people get it. And we have to, obviously, it is our responsibility to explain it in the way that they will be, that will be comprehensible. And yes, if we don't understand something is being advised, ask why. And there, hopefully, you will find that this, quite distressing. And I appreciate this is distressing if they're getting, conflicting, what is perceived as conflicting advice, then who do they believe? What do they follow? But ask the question, look at the answer. Does the answer make sense to you? Would be my advice.
That's really useful, actually. And I think probably also actually saying, well, someone else told me to do X is probably quite useful too, isn't it? Angela, there was also some really interesting information in the survey about counselling. So only half of the patients who responded had had counselling, but more would have liked it if they could have done. And paying was often a problem when treatment is so expensive anyway. Do you think that counselling should just be a part of treatment that's included always, rather than people having to pay extra for it?
Yeah, yes, absolutely. I think the fact that 78% of respondents said they would have accessed counselling if it was available and free to them really kind of highlights both the value and the need of counselling. And I really think that should be a wake-up call for clinics to be providing at least a number of sessions for our patients included in the treatment costs.
So at the moment, does that happen in some places? And I mean, what's the situation now when it comes to paying?
Unfortunately, I think that, well, unfortunately, there is huge disparity across all clinics in the UK. So some clinics will provide counselling as part of their treatment costs, and a number of counselling sessions, as many as 6 sessions per treatment cycle. Other clinics will provide one counselling session, and some clinics will provide counselling, but it would be an additional cost for patients. So there's a huge disparity, unfortunately, across clinics at the moment.
So Claire, what's the legal obligation for clinics when it comes to counselling?
So according to the law, clinics must offer patients counselling, but as Angela says, offering counselling can mean a variety of things. So it could be by saying to patients, well, you can have X number of sessions, and that's including in the price, or it could say we have a counsellor, on site or who can see you remotely, and here's the additional charge. Or it could be, as much as just giving someone a leaflet and saying, here's the information about counselling. So I think it's very sad, the variety of different ways people are offered counselling and how clinics are fulfilling their obligations on the law. And we know that not every patient will want formal counselling, but it is such an important part of many people's treatment. And as we've said before, this is a particular area of healthcare and particular experience in people's lives where they are particularly vulnerable, and counselling can play a really valuable role in supporting patients both during treatment and actually for many years after. Again, to reassure people that this is something we look at on inspection, and our inspectors not only look at the counselling provision, but the qualifications of the counsellor as well, in the same way they look at the qualifications of the nurses and the doctors and the embryologists, and that is reported back. Every inspection report for every UK clinic can be found on the clinic details on our website. So if this is something that a patient is particularly interested in, they could look at up. But as I said, to go back to the beginning, the law requires clinics to offer counselling. That doesn't necessarily mean it's included in the particular patient package.
That's really useful to know. So anyone who's having treatment at a UK clinic should actually be offered counselling, even if it's not something that the clinic's going to actually include in the price of your treatment. It's a really important message. We've got a few more questions left, but if any of you have any questions you'd like to ask, please do feel free to just pop them in the chat box. Ephia, I wanted to just come back to you, because one of the things that came out in this survey in comparison to the last one we did, looking at a very similar kind of group a number of years ago, was that there have been a really big increase in the number of patients making use of Fertility Network UK services and finding that support really beneficial. Do you think clinics ought to be doing more to signpost to the charity? Because one of the things we do know is that patients don't often find out about us from their clinics.
Absolutely. I just wanted to also go back to the counselling question in terms of how are clinics equipped to provide this service. It's not just about the payments and about private clinics. The NHS clinics themselves are struggling, especially with staffing and whether they can offer very timely counselling. So yes, offer of counselling is made, but if the first appointment is 3 months later, is that good enough? You see, there are sort of huge discrepancies even within the NHS, and as NHS units also kind of have to go through so many other sort of financial difficulties and issues. So this is another thing to contend with. And here, yes, absolutely. And Fertility Network UK is a huge resource. And NHS has a tradition of making use of these very valuable charities, such as in miscarriage, sort of a miscarriage counselling, any stillbirth counselling, and certainly Fertility Network UK. And there needs to be a drive. I think there needs to be, there are posters around, but then each unit may do something, or center may do things differently. But absolutely, why it is difficult to fathom why, when there is a service available there, why wouldn't we signpost? Why do people just happen to find it when they do their own searches, or somebody else has recommended, somebody non-clinical has recommended? Absolutely, I couldn't agree more.
We've got one question about workplace here, which I'm not going to ask because we've got a whole webinar coming up tomorrow on workplace, which is the right place to ask that, because you've got your experts on fertility in the workplace joining you tomorrow. We've got another question about the immigration health surcharge and whether that you're eligible for treatment. Ephia, you're nodding. What's the answer to that one? Do you know?
This is very, very distressing. I don't know if everybody is aware that, yes, NHS funding for fertility treatments is not available for those with certain visa status where they pay a surcharge. This has got nothing to do with, any of the clinicians or even CCGs. This is a Department of Health guidance, so it's got to be addressed at that level.
Someone's asked a question which I think is what every one of us would really like to ask. Why is it a postcode lottery? Someone who said they only got one NHS treatment, it didn't work. They got 17 eggs with no fertilisation, so that was the end. But other people can have 3 rounds. I mean, how do we justify that, really?
I know we do not give individual advice in this, but I would challenge this. If there was no fertilization from 17 eggs, so I would suggest that individual, sorry, I can't see them, but to read their policy, get empowerment, read the policy which is available on the public domain, and is an abandoned or cancel cycle, etc., included. Because if IVF was carried out and none of the eggs fertilized, they should be eligible for another attempt with ICSI. That is how we read the guidance, but I would suggest they read their own guidance on that. But why? If we had known, and we would obviously perhaps not had that problem. But I mean, I won't be able to answer that question. But we know that the funding is arranged at these local levels. So they have a certain amount of money, and then they have to distribute the money in a certain way. And it is that will govern, what they fund and how they fund. So it's not that, as I said, it's not often an individual's decision, but there must also be ways in which this can be countered. It's very sad, it doesn't happen anywhere else apart from fertility and such as IVF treatment and fertility preservation as well, which I had highlighted. I had highlighted the discrepancy that exists in policies when offering fertility preservation for medical reasons as well. Sorry, I know it is disappointing to not have a clear-cut answer, but raise the voice, ask, go to the MPs and ask why. Why should they be penalized for having a certain postcode? So
you've slightly answered our next question, Ephia, which is what can individuals do to improve fairness? And we would certainly say all of those kind of things. I think that, we see sometimes that people writing to MPs can actually make a real difference, because once MPs start to ask questions, it can really make a difference. And I know it can be really hard to speak about things like fertility. It can be quite a challenge to actually want to be open and want to be public about it, but it can make a difference. I mean, Claire, do you see that sometimes, that people campaigning for things can actually make a difference?
Yeah, we do. I mean, one of the things that's frustrating when we bring this up, the postcode lottery or the inequalities up in public, we hear people say, oh, no one's writing to their MP about. Now, that's kind of not, things shouldn't change because MPs hear about it. But the more we can get people's voices heard, I think the better. So I would say that if something has, if you have an experience of this so-called postcode lottery, that it is worth, right, you know, what have you got to lose? The email addresses, just Google it, you can send a, 2-minute email. The other thing is that sometimes CCGs change decisions. And I have heard of cases, and I think they were actually through Fertility Network, where an MP wrote on behalf of the constituents' behalf to the CCG, and sort of the CCG quite quickly made a decision to kind of overturn their decision. So again, it shouldn't be this hard, should it? But unfortunately, that's the situation we're in. So there is support from Fertility Network. It is worth emailing MPs. CCGs do change their decisions, and often clinics will help you with that as well. If they think that there's a case to be made to the CCG, they will support you as well.
Yeah, I think that's really true. And I think the one thing that we have seen, as Ephia mentioned earlier, is that where commissioners do actually do a proper consultation, like the one that we saw in London, and where they do actually really take expert advice, talk to the public and talk to fertility patients, they're often much more understanding and do realise the importance of funding, as NICE suggests. We've got another question, just one which I think is for you, Ephia, which is around why the NHS don't ask patients to look at certain additional tests, which they're saying could save thousands of pounds actually, things like thyroid and sperm DNA fragmentation. But is it the case, Ephia, that some of those things are not necessarily things that everyone agrees with?
Yes, absolutely correct. Again, I would recommend that the NICE guidance, so we cannot be picking and choosing. So we will say, oh, we follow NICE guidance with the 3 cycles, fresh cycles, but we will not follow NICE guidance when it comes to investigations and treatment. So because why NICE guidance? Because all these tests and treatments are put through an assessment of their evidence, clinical effectiveness, yes, and whether, therefore, it's rational to be doing it. And yeah, absolutely. Many tests are not available on the NHS, not because NHS care is substandard. Far from it. Let me also, because I'm a big advocate of the NHS, when things don't go quite right in the private sector, where does the care take place? In the NHS. So let's, therefore, give credit where it's due. Because unless there's clear evidence, then we will have to fund so many other things. And then we will lose funding for the essential things. So if we start investigating, there's only a certain pot of money. So we will have to spend judiciously. And where there's a clear advantage, it is us. We will fight for it. We do it all the time. We put in applications there for medicines called UMC. We do individual funding requests. We do it. The clinicians do it. But there are other tests that are almost considered to be optional extras, and often they don't change management.
That's really useful to know. Thanks, Ephia. Claire's put the website in the chat for anyone who wanted to ask about that. It's www.hfea.gov.uk, and there really is loads of really helpful advice and information there. We've only got just 5 minutes left, and I wanted to ask each of you a final question, which is really, what do you think you'd like to see change, or what do you think could make a real difference for fertility patients for the future? If there was one thing you could do to make a difference, what would it be? And Claire, I was going to come to you first.
Thanks. Well, I mean, I really hope that if we were talking about this in kind of another 5 years' time, that we wouldn't be talking about all the inequalities and inequalities both in access and outcomes for different people, depending where they live, or which ethnic minority group they may come from, or even which relationship they're in. I think that's, that's something I would really like to change. And the other thing I'd like to change is, I've spent a lot of time tonight saying, that's really awful. It's a shame the HFEA can't do anything about it. So we do, I think, a good job within the confines of a law that we we have to interpret it, which is basically over 30 years old. And medicine, healthcare, and particularly fertility medicine has changed a lot in the last 30 years. So I'd really like the ability to change the law and make us, enable us to act much more on behalf of patients and do an even better job than I hope we do today.
Thanks, Claire. What about you, Angela?
I think I would really like to see clinics really embed patient support and a set number of counselling sessions per treatment cycle, not as an add-on, but part of their care package, to providing our patients with the best possible care that they could have in the situation that they're in.
Thank you. And what about you, finally, Ephia?
Can I take two things I would like to see change, amongst other things? One is funding. So remove this disparity, and it is same funding available to all. Criteria, yes, but only, only in terms of just improvement of health, and where a particular treatment is certainly not going to work. So I also have some reservations about the current ovarian reserve criteria used. So fewer barriers to accessing treatment, and that would be to all, irrespective of, ethnicity, race, etc., socioeconomic condition. And the other thing I would really like to change, and which we haven't been successful so far, is to get funding for surrogacy. Everywhere else we have, we fought for funding for single women. There is, yes, they still have to have their 6 cycles, but there is funding for single women, for same sex, but there is no funding for surrogacy for people who do not have a functioning uterus, and also for same-sex men, so we can see this gender inequality existing just there. So I would like to see funding for surrogacy.
I have to say I'd like to see all of your things, every single thing that you've mentioned, because I think if we had all of those changes, the world would be a much nicer place. And I think if that happened, the next time we did a report like this, it would look a lot less bleak, I have to say. Thank you all for joining us. I just wanted to let you all know that we have got webinars every evening this week. So tomorrow we're going to be talking about fertility in the workplace, and the person who had a workplace question earlier, that's your time to answer that tomorrow. Nikki Aitken MP will be joining us tomorrow, and along with Anya Sizer, who is our fertility in the workplace expert. On Wednesday, we've got a webinar on men and fertility, which promises to be really interesting. We've got a number of men joining that webinar to talk. On Thursday, we're going to be talking about fertility education. We're going to be talking about some of the work that Fertility Network UK does around fertility education. We're also going to be joined by Professor Joyce Harper. And then on Friday at lunchtime, we'll be talking about some of the barriers to treatment with consultant Stuart Lavery. So it's a really interesting week, lots of really interesting webinars coming up. Do join us for any that you find interesting. But I wanted to say a huge thank you to Claire, Angela and Ephia. It's been really interesting this evening. Thank you so much for answering lots and lots of questions about lots of different things, and let's hope that all of your wishes for the future come true sooner rather than later. And thank you all for joining us, and we hope to see you later in the week. Goodbye.